Morning. I am really delighted that you're here. Delighted to have the chance. Thank Nicole for giving me a chance to talk a bit about this. This is my passion, really. I'm a clinical psychologist by training, and I'm a professor up the road. And I do research in the treatment of assessment and treatment of suicidal risk. And Nicole asked me to talk about professional training. I'm going to get to that in a roundabout way with a little bit of backstory, but it's meaningful to where we are today. When I first worked in mental health, I was a psych tech out in Northern Virginia, a hospital called Dominion Hospital, and I was working on a nursing staff. And this is a little bit of a time ago, but it was not unusual in those days for people to be hospitalized who weren't suicidal, and they were hospitalized actually for more than 5 or 6 days. It would not be uncommon for people to be hospitalized for months on end. And there was actually treatment in those inpatient settings. You would get a full psychological workup and an assessment battery. You would meet with your psychiatrist every day. You might meet with a psychotherapist as well. You'd be in various groups. You might be in psychodrama and art therapy. And you might have a significant length of stay where if you did really well, you'd work through a milieu level system and then go out for a pass for about an hour. And if you did really well next week, you go on a pass for 2 hours. And you kind of work your way out of the hospital. And your disposition was wildly different than where you were when you first came in. That model virtually doesn't exist. There are 2 hospitals in the United States where you still can get that kind of care. It's very expensive, and there are wait lists to get that kind of care. Maybe I hazard a guess how long a typical length of an inpatient stay is?
4 days. 3 days.
It might well be overnight. I'm not joking. The mode is about 2 or 3 days, and the national average is about 6 days. And what's true about that experience is that there's not much treatment that goes on outside of prescribing medicines. And that's criminal, because medicines really have a very limited track record of treating suicidal risk. And that's surprising for a lot of people. You think, treat depression, treat the schizophrenia, there goes the suicide. So far, the evidence base for that approach is very, very limited or mixed at best. So fast forward 30 years, we now live in a country, a very wealthy country, where people that suffer and struggle and are suicidal, and again, 9.8 million is the number I quote. You've heard 10, 11, 12 million people that have suicidal thoughts each year. But a lot of suffering people and families that care about these people are floundering. And the worst part about this is that the public and the media and even our politicians, think that there's a safety net. Think that there's a system out there where, of course, there must be a place for my son or daughter or my husband or spouse, to get proper care. And the fact of the matter is, that's pretty limited. And so from my particular bias, in the field of mental health, you have a topic that is certainly stigmatized, but it's also a joke. When you think about movies or mass media or sitcoms, mental health care is a joke, and mental health providers are a joke until you need us. And then when you need us, we're suddenly transformed into magicians who can read minds and have unlimited influence and can lock people up till they come to their senses. And that does not map onto reality. Because the reality is the bar is getting higher and higher to hospitalize somebody. And if you don't have a suicide attempt, you're going to be hard-pressed to get a pre-certification from a private insurer or from a health plan to get somebody admitted for a day or 2 of treatment, a day or 2 of inpatient care. Right? And, and you pretty much have to be suicidal or homicidal to get hospitalized anymore. So the situation that we have is a model whereby, we're still thinking 30 years ago that a suicidal person belongs in the hospital, and then when they go there, they get treatment. What do I say to a brother who had a highly decorated combat veteran, dear and near to him, who was special operations, multiply deployed, served the nation honorably, who leaves the Army, gets very depressed, becomes suicidal, and then gets hospitalized, and is in the hospital for 10 days, and shoots himself the day after discharge? What I'm saying to that man is, I'm sorry for your loss, and the tragedy is your brother probably didn't get much care while he was in the hospital. he probably sat around in a day room, watched a lot of TV, talked to a number of other patients, and got medicated. Now, my goal here is not just to disparage inpatient care, but we need to do better. We need actual suicide-specific treatment to occur in inpatient settings. And that's actually quite rare, believe it or not. At a minimum, Bob Gebbia mentioned this the other day, at a minimum, there need to be standards of care for inpatient psychiatric work, for primary care, and for emergency departments. Do you know that our country does not have minimal standards of care or guidelines for providers to work with suicidal patients in those settings? There's no standard. So I'm on a committee with Mike Hogan and others that is trying to promulgate minimal standards of care for primary care, for EDs, and psychiatric care that involve, shockingly, information, psychoeducation about the National Lifeline, information about effective care, information about means restriction, and God forbid bring a family member come in to talk about discharge and what might be the virtue of making that environment more secure. This is low-hanging fruit. This is a tough sell to get people thinking about the National Lifeline and safety planning and means restriction. But we're on that case. Here's the really criminal part from my vantage point. Mental health professionals are still, in many ways, stuck in a 30-year model. Especially non-psychiatrists think that a suicidal person still belongs in a hospital, and too many of them are still using no-harm contracts, which are crazy at their face, which is promise me you won't kill yourself, sign this piece of paper until I see you next week. Shame on them. They should, at a minimum, be using safety plans or crisis response plans or stabilization plans that talk about what you will do should you get in a suicidal dark moment, right? What your resources are, what are the things that you can do to cope with your situation if you get in a really desperate place. Most mental health professionals don't know that. Most mental health professionals are still with sort of an asylum kind of model of putting people in the hospital. And here's the really bizarre truth around that. Once somebody's hospitalized, they're forever at increased risk. Right? So an inpatient psychiatric hospitalization actually increases statistically the risk forever. And the risk is particularly high the 2 weeks after discharge. And that risk extends out for weeks, even to the first year post-discharge. So we got a grant from AFSP, a focus grant, focusing on people coming out of the hospital, because we know those 2 weeks post-discharge are extraordinarily high-risk period. And that's one of the things that we've been able to do with that kind of resource. So we have a situation where mental health professionals are caught in this as well. They aren't trained in how to work with suicidal people. So the idea that you would get curricular training in a clinical psychology PhD program, or in a residency program or medical school, or a nursing program, or a social work program, or a counseling program, that happens less than a third of the time. Even an hour, a single hour on the assessment and treatment of suicidal risk. Most mental health professionals learn about working with suicidal patients by having suicidal patients in their placements, in their residency, in their internships, and in their practicums. And then they raise to their supervisor saying, what do I do? And then the supervisor, to varying degrees, tells them what to do. So we've got a pretty broken model. And we've got a model that is not really delivering on where the need is, which is to treat suicide specifically. And what the research literature shows, the randomized controlled trials, which is really the gold standard of what actually works, shows that basically psychological treatments work. And that's dialectical behavior therapy, or DBT, 2 forms of cognitive therapy called cognitive therapy for suicide prevention, or brief cognitive behavioral therapy, BCBT, or our intervention, which is called CAMS. These have been proven to work in replicated multiple randomized controlled trials, but they're not used that much at all. Because we want to believe that medicine is going to be the solution. Now, for some patients, medicine is wildly helpful. The FDA approves one medicine called clozapine for the treatment of suicidal risk, but that study has never been replicated. There's evidence that lithium is effective for bipolar patients, people with manic depressive illness, but the RCT, the randomized controlled trial, that has not been replicated. So we have a lot of magical thinking about this issue in the public sector. And we think that medicine's going to do more than it does. And maybe that randomized controlled trial is now being done. But so far, medicines only help the cause. They don't treat the cause. And the psychological treatments that are effective are not widely used. And the worst part as a psychologist that I think about is that we don't feel like we're trained or able to work with suicidal people, that the real doctors, the psychiatrists, need to work with those people. And so we think of getting rid of these clients and patients versus working with them and embracing them and doing treatments that actually are effective. So that's all a lot of opinion, but a lot of that opinion is based on data and not just me soapboxing. And it comes full circle to this idea that if the public believes that mental health professionals know more than they do, and families understandably want their loved ones to be properly cared for, then we've got to get mental health professionals to actually get trained, not like pretend trained, to actually get trained in evidence-based assessments and treatments. So Nicole knows this. I am not a fan of coercive treatment. When you look at the literature on mandated treatment, it basically doesn't work because the motivation is lacking. Right? Now, clever clinicians can work with patients who are mandated treatment and get them sometimes hooked. But mostly treatment works when the patient wants to seek the treatment. I think the same issue maps onto mental health care. And most professionals do not want training in this area. They just don't. But if we don't do something, our patients are going to continue to die. And clinicians are going to have their head in the sand. And they're not going to save lives like we know they can be saved by doing things that actually work. So that's a long-winded way of saying that's why this issue's come to the fore. Is that if I'm a clinical psychologist and I'm licensed here in the district, every 2 years I've got to get training in ethics, which I actually teach in a PhD program, but I got to get it anyway. And I got to get training in diversity. And that's that's required for my license. Suicide is the fatality of mental health. And if we don't get trained, we're not going to save lives. So I've become a convert, and I've come around to thinking, yeah, we got to make people get trained. We got to make people learn that there are assessments and treatments that are effective, and that clinical care can actually save lives. And we got to stop pretending that locking people up or throwing medicine at them is going to make the difference, when the difference really is a therapeutic relationship where you're treating the things that make people suicidal. It's very simple. So I could go on and on about this. I feel very strong about this topic. But really what we need, frankly, is legislation that makes people learn. So that the disconnect between what the public and media thinks is true about mental health care actually has some semblance of connection and reality. That if as a clinical psychologist I'm referred a patient, I have some semblance of mind of what to do to engage with this person around the nature of their suicidal struggle and actually treat that struggle. And I don't really see another way around it because the training programs aren't picking up on this. The state licensure boards aren't picking up on this. But there has been a modicum of traction. In how many states? 3, 4?
It's more like 6 or 7.
6 or 7, I stand corrected. There's progress right there. Is that requiring mental health professionals to get training is going to be one way to get there. And my final thought is this. There's training and there's training. And one of the things that is problematic in the Washington State bill, for example, which is the first and the most pervasive bill, is that the training doesn't have to be evidence-based. So, which is a big problem. It can be best practice, whatever that is. So best practice typically is kind of like, yeah, I think this is good. And A, we don't know if it's good, and B, the thing that people never think about, could it be harmful? Because you never think that. That's why I've spent, basically 30 years doing randomized controlled trials, because I want to prove that my intervention works, and I also want to prove it doesn't cause harm, which people never think about. Right? So I probably go on my time, but to me, this is a huge issue that we can move the ball on. And as the representative shared with us in the previous session, this doesn't necessarily mean a lot of money. The big challenge is, though, the trade associations, the professional trade associations, like in California, where Jerry Brown vetoed the bill because the professional trade associations said, "Oh, we already know how to do this." That is not true. That is, and I got the data. It is not true that mental health professionals know how to treat this issue. Shame on them. That bill should never have been vetoed. But they were a powerful lobbying group. So I have more to say, but I'll leave it at that.
And before we jump ahead, we are working toward having a model piece of legislation that would speak to all the issues that David just spoke about. We do have information on those 6 or 7 bills that have already passed. Up on our website, we have a public policy priorities section, and health professional training is one that we have built out with issue briefs and examples and things like that for you guys to take a look at. So if this is an issue that you would be interested in trying to move forward in your state, we have resources. We have, wonderful experts like David that we can connect with and see if we can get something moving. So with that, I'm going to turn it over to
Nicole, could you speak to the issue when the model legislation might be made available?
I don't have a time for you just yet. It's on my priority list for the next 6 months, but that's all I can say for right now. Because I really don't want to throw a date out there and then not meet it. So here's what we're working on.
Okay. Well, first of all, can you hear me?
Yes.
Okay, perfect. All right, so I'm excited to be here today. My name is Amy Loudermilk. I'm the Director of Government Affairs at the Trevor Project. I just have to say that presentation was so powerful, David, and I just learned so much from just being here, so thank you for that, really. And speaking of legislation and lobbying, I think this is a perfect transition. I'm really here today to talk about the K-12 education and training for school professionals. But first, I just want to make sure everybody is aware of what the Trevor Project is. We're the leading national organization providing crisis intervention and suicide prevention services to LGBTQ youth. These are some of the things that we do. We are going to make the PowerPoints available to you later on, so you will see that I'm going to skip some things just because I want you to have that information in case it's helpful to you as a resource. So here's what I'm going to cover today in 10 minutes or less. All right, so first I'm going to talk about partnerships, the importance of partnerships, what kind of partnerships look like, both on the national and the state level. I'm going to talk about state policy advocacy and the importance of building coalitions, who you might want to have in those coalitions, and how to strategize around having these types of bills introduced in states. Also going to talk about legislative drafting and resources that AFSP and we have for you. I'm going to talk about testimony and what considerations you should have. And then I'm going to talk about the post-session debrief, which is really important, and I think a lot of folks forget about, including myself sometimes, so I'll throw myself under the bus as well, but is really important nonetheless. All right, so partnerships and coalitions. As Nicole mentioned, the Trevor Project and AFSP partner in a number of ways, both on the national and the federal level, national and the state level. Excuse me, it's super early for me. And it feels like it's Friday for some reason. Okay, so we partner in a number of ways. One of the examples I'll just throw out there really quickly is the 21st Century Cures Act, which was really important mental health reform that I know pretty much everybody in this room was probably involved with last year. So thank you for your efforts on that. And then we also partner really closely when it comes to the K-12 state bills on education and training. So those are some of the partnerships that we have, and I'll talk a little bit about how that manifests in the states in a few minutes. And then working in coalitions. working in coalitions is so incredibly important, not just because it's not fun being the only person pushing for something. You want help, and quite frankly, that help will broaden your resources, will make you less stressed, and will help all of the members of the coalition work more effectively and I think quickly towards the passage of a particular bill. So one of the things that we certainly encourage and we have done in different states is for local AFSP chapters to partner up with Trevor Ambassadors, which is pretty much a chapter of people who are involved with the Trevor Project, are trained very similarly that in the way that AFSP volunteers and advocates are trained, and are really there to help advance public policy and things like that. Trevor Ambassadors exist in most major cities, so they are great folks to partner up with as well. Another organization that's not listed here that I'll also throw out are PFLAG chapters. They are traditionally focused on the family and the parents of LGBT folks, but a lot of PFLAG chapters were started specifically because a suicide occurred there, and so they're very much focused on suicide prevention and training and awareness. So some other key coalition partners, you probably know a lot of this. Anybody involved in the school system is a great person to have on your side, whether they're a school board member, they're a teacher, maybe they're an alumni of a particular school. Really anybody who can speak and might have a little connection or pull in the school system. You really like those people who have influence, so please reach out to them and get them involved in your coalition. Obviously, people who can speak to personal experience and bring this issue home, whether they are people with lived mental health experience, they are suicide attempt or suicide loss survivors, are incredibly important, although we know we want to allow people to speak at their own pace and things like that, so that's also another consideration to have. And then also, I throw out the idea of community leaders. They might be really hyper-local elected officials. They might be a local priest or imam or something like that. Community and religious leaders are also often have a lot of influence, so they're great people to think about. And then there's a whole host of other people. So when you are gathering your stakeholders and partners and getting ready to introduce a bill, I encourage you to really brainstorm and think about other partners. So one thing about coalitions is that you want to have them in place before you have your bill drop, right? So important. You want to have those people on your side. You want to have people at the ready to speak at maybe press conferences once a bill gets released. And you want to have really all of your ducks in a row. So that's very important to have. Also, you want to strategize before you even get to the bill introduction. Who should introduce your bill? One of the things that we have really focused on is that because these bills tend to get referred to committees on education, is try to go to the chair of the Committee on Education in your state and get them to introduce the bill. That will help you enormously. If you can do it, I highly recommend it. Also, make sure that you reach out and get as many co-sponsors as possible. Think about potential connections that individual legislators may have to an issue and play to those connections. Really use those to your advantage. And then also make sure that you are utilizing all of your coalition partners to help create materials, whether they're fact sheets, an overview of the bill, talking points, what have you. These are really important things to have in place. Now, in terms of actual legislation, AFSP has model legislation. It's passed in many states, which is fantastic. We also have sort of an enhanced version, perhaps, if you will, where it lists specific groups of people, certain populations. For us, LGBTQ youth is one of those populations that is at a high risk of suicide. And so you might be able to get a bill that requires specific focus and attention and training for those high risk groups, which is a great option if you have that ability in your state, if there's sort of the political environment for that. We also have a model school policy, which AFSP, the Trevor Project, the American School Counselors Association, and the National Association of School Psychologists worked very hard on. It's available both on AFSP's website and the Trevor Project's website. There is more information on the policy throughout here. I'm not going to go into detail because of time. I always talk too much. But it's there, and it's for you to use. It covers prevention, intervention, and postvention, which we all know is really important information. And then also, once we put out this policy, we got a lot of feedback that said, this is great, we love it, thank you so much. But how in the world do we actually get this policy to be like in our school manual? How does it, officially get in there? So one of the things that we've done recently is drafted an adoption toolkit, which goes over the different ways that you can get it in, whether it's working within the school system or whether it's going and having these things legislated like we've been talking about soon. That will be released in the next coming months. So look for that on Trevor's website, on AFSP's website. And we're really excited about that. So these are other slides that I told you would be wonderful resource material. You can go through these along with the model policy, which I think will really help you in understanding different pieces of it. These are the higher than average at-risk groups that I mentioned that can be enumerated in your bills. And so I want to speak to testimony a little bit. When it comes to a hearing, when you actually have a hearing, yay, that's a successful milestone. You want to make sure that you're strategizing about who is speaking about what, and are we covering all the points, right? So definitely coalition members should speak from their own perspective, whatever that is, whether they are a professional working in the field, whether they're a volunteer with lived experience, whatever their perspective is, make sure that they speak because they are the experts, in fact, on their own experience, of course. And then I would leave it to the more experienced volunteers or perhaps professionals who you're partnering with to preemptively answer questions that you're probably going to get asked during the hearing. One of them is always, this is going to cost so much money. Where's the money going to come from? How much is it going to cost? What are we going to do about that? So make sure that you preemptively address that so you don't have to get that line of questioning, or you can more easily answer it when you do. And if you do a really great job, you'll have really awesome success stories like these, which I always love to put in. The adoption toolkit, as I mentioned, is coming out soon. It is actually just broken up into 4 steps. I have a little preview for you here so you can see what folks would need to do. And then I really want to focus on the post-session debrief, which is incredibly important. Just because your bill didn't pass this session does not mean that that's a failure or that you didn't succeed. In fact, there could be a number of different factors which you can judge your success on. And I think it's really important as advocates to remind ourselves of these, because we get so focused on the end goal and is it passed and did the governor sign it? But these things sometimes take time. So we really want to make sure that we're assessing these kinds of things. So one of the things that you really want to assess, the number of co-sponsors that you had. Every time you introduce this, if you get more co-sponsors, that's a huge success. If you didn't get a lot of co-sponsors, why do you think that is? Do you think you might be able to strategize around different messaging next time? How far the bill went in the legislative process. If it goes a little more each time, that's a great success. The number of people and the types of people testifying at the hearing, the more diversity you get, I think the easier the sell it is. And you can really show that there are a great number of people in the community behind this particular bill. Also, what you do not in the state capitol, whether it's you can write an op-ed, whether you, conduct a press conference when the bill is introduced, or perhaps when the bill is stalled to get, things moving. And also, again, the types of coalition members. There are all kinds of different folks in the community who we might not necessarily think of to go to. So I just encourage you really to be thoughtful when you start, and don't be afraid to go up and talk to, some really influential person who you never thought would be behind you, and, tell a story. And more often than not, they'll join you. So those are some really good things to think of when you do your post-session debrief, which will help you when you come back next year if you do have to do that. It's not a failure. I just have to repeat that because this type of work is very much a marathon, not a sprint, right? And then I just have my contact information at the end, so please feel free to reach out with any questions or concerns you have. Just like Nicole, I'm happy to strategize and answer questions and provide advice for how to get around roadblocks. So with that, I'm going to turn it over to you. Yes, let me move out of your way.
While Maggie's getting situated, so Amy, thank you so much. We really we didn't go into as much detail about the whys behind we're involved in K through 12 because we've been doing this for a while. I think you guys are all a lot of you are from states where this is already required or at least encouraged in some way. Just by a show of hands, anyone know that their state does require that personnel get trained K through 12 space? Okay. What about school policy? Any states that require school policy? Okay, so that's fewer hands. So when Amy was talking about, you might not get all the way at first, we've got to start looking at incremental success. So if we're not able to get a full comprehensive bill that looks like AFSP's model at the very start, that's okay. We can just look at the training piece, or we can just look at the policy piece. And the policy piece with the release of the model policy that Amy was referring to that we did together really prompted us to change our model legislation to incorporate that language. So a lot of the bills that were passed prior to 2014 didn't talk about policy at all at the school district level. It really just talked about training, and then we were like, of course it makes sense that there's policies and procedures in place to support the training that you're getting once a year, or once every other year, once every 5 years, or just once, ever. It happens in some states. So we can come back, if your state already requires personnel training, you can come back and maybe amend that to include school policy requirements at the school district level. So there's room for us to move there, but again, we have comprehensive information on the whys, getting in front of some of those funding questions about how AFSP chapters can offset the cost of this type of legislation is available to you. So with that, I'm going to turn it back over to Maggie. Show of hands, do you have higher education legislation in your state? All right, much fewer hands. So this is a much newer issue. Maggie is the expert on what AFSP is doing in this space, so I'm happy to have her speak to you now.
Great, thank you, Nicole. So I am Maggie Mortale. I'm the director of the Interactive Screening Program at AFSP in the New York City office. And as part of our public policy priority for higher education specifically, we want to make sure that all college and university students, staff, faculty, know what care is available to students, mental health specifically, and how to access that care both on and off campus. So what I'm going to do today is just talk to you briefly about what AFSP has been doing in this space programmatically and continues to do to support these policies. So I'll start by just talking a little bit about the students that we specifically through the Interactive Screening Program and through our work in higher education are looking at and targeting. One of the key goals of ISP from the very beginning was to get an understanding of who are students who are at-risk students, and what does that mean? What does that look like? And so specifically, we're looking at students who are not necessarily at the point of crisis. In fact, we hope to reach that population of students way before crises emerge, and are really with this program taking a quite upstream approach to get access to students and connect them with care before crises emerge. So typically what we're seeing statistically is that about 15% of college students are suffering from depression or other mental health conditions. It's a bit higher when we include substance use and abuse disorders, and then unfortunately, 24% of those students reported treatment within the past year. So we have a very low number, although it's gone up in the last few years, and we're seeing an increase in students accessing care, but what we're not seeing is the group of specifically at-risk students have much lower levels of help-seeking behavior on campus. And so our focus is really on the students who are not reaching out and not accessing those services. And college students in particular are a unique population, right? So they have mental health services available to them. Most college campuses in the United States have some type of a counseling center available. If not on campus, it is through a partnership college or through a local mental health facility. And so this is a time in your life when you have access to care. And so when we typically talk about barriers, specifically in the adult population, a lot of times it has to do with access, right? Like you live in a rural community and you don't have a mental health professional nearby, or you don't have a way to get a ride to your local doctor. And so it's really those sort of more physical barriers, external barriers to care. Specifically with ISP and what we're looking at with our college students is these internal barriers to care. Because if college students have access to mental health, oftentimes they're already paying for it, right, as part of their tuition, so cost may not even be a barrier. What's sort of getting in their way? What's preventing them from connecting with the care that is available to them and on campus? And so really we're looking at these internal barriers. I have some of them for you here. Certainly negative attitudes about mental health treatment. There's oftentimes a lot of misconceptions about college counseling centers and the issues around confidentiality or fear of sanctions for coming forward with a mental health condition or a suicidal crisis, like being forced to take a semester off, things like that. And as well as issues about, does this go on their permanent record for getting counseling or therapy at the college? Will this impact their ability to get into the grad school of their choice or a job after college? And so a lot of times there's these unanswered questions that students have that are really putting up these barriers to them taking the next step and reaching out for help, even when they know help is available and they know how to access it. So the difference then too is making sure that we have a way not only to ensure that all students know where help is and how to get access to help, but that there are different methods available for how they then connect through care. So what we're doing with the interactive screening program is looking to add one more way for students on college campuses to get help and access care. And while many college counseling centers do terrific amounts of outreach, they're getting involved in our campus walks. They have wellness and fresh check days on campus that I know many of our chapters are involved in. They have student groups like Active Minds that are working to ensure that students know where services are and how to get connected with services. But again, when we're looking at students that may have these significant barriers in terms of confidentiality and anonymity, we want to add an additional way for them to get connected. So what we do through the interactive screening program is we work uniquely with the College Counseling Center. We conduct an assessment of their services and look at, who are the students that they're seeing in their counseling center, and then what groups of students are really low utilizers of services. So some examples of that are probably most common consistently across college campuses are international students, transfer students, certainly student veterans who actually have very unique services and additional services on campus that they really may not know about. So what we do is we really work directly with the counseling center staff, we develop and implement what we call their ISP, or Interactive Screening Program website. It is completely branded as their own. They typically will, title it something about their suicide prevention initiatives on college campuses. So, for example, Emory University in Atlanta, Georgia, they call it Emory Cares for You, and it's their Emory Cares for You program, and part of that is this ISP site. What the site allows is for students to either access the website on their own, whether the link is posted on the Campus Counseling Center website under Ways to Connect, or it's through a targeted approach whereby the counseling centers are thinking, okay, well, we know it's transfer students. Let's email an invitation to 200 transfer students and tell them about this program. And so there's that outreach component too. And it also then allows students to log on to the website. They sign up with their own user ID so that they're completely anonymous, and I'll talk a little bit more about that next. And take a questionnaire that's not necessarily designed to serve as a diagnostic tool, but more as a way to initiate a conversation and a dialogue with the counselor at the counseling center. Because unlike other screening programs, this one has a different approach where instead of getting an automated response at the end of the screening, they're told that a counselor from the counseling center will respond within 24 hours. And so there's this other added end to the program where the counselor actually gets notified and can log in and personally respond to this student. And that's really a way to not just say, you're depressed and you're not sleeping and sort of listing off these symptoms, but to say, I noticed that you're, feeling down a lot of the time, and you said that parking, services can be particularly stressful for you. I have trouble with parking on campus, and I understand the stress. I'd really like to talk with you about your experiences and see what we can do to strategize on, on how you're doing or how to, handle this situation. So it really is this nice personal connection and a way to answer some of those questions that students have. Well, do I have to pay for this, or is it really confidential? My dad would never let me, go to counseling or therapy. Will my parents find out? Something along those lines, where they have this platform now in order to do it. It's not a clinical service by any means, and not a replacement for that at all. It's really to engage these students into clinical services when they need it most, and in a timely way. So I'll talk a little bit about the key principles. I spoke briefly on student anonymity. So when we talk about those barriers to care and confidentiality and fear of sanctions sort of paired in with that, that really prevents so many students from reaching out and getting help. And there are not many ways for students to connect with college counseling centers where they can be anonymous and explore services anonymously. And so this remains a core component of the program. We ensure that students have way more information about the services that are available. There's the National Suicide Prevention Lifeline and the Crisis Text Line and the Trevor Line on every single page of our website, so that students know where to go for crisis resources and how to get connected offline. But we do want to make sure that when the students are connecting with the college counseling center, they are in a safe way asking these questions and exploring treatment services. The next is that personalized connection with counselors. That is really at the heart of this program, where they can start to form a bit of a relationship that will ease some of those barriers and allow them to come in and meet with the counselor face to face. We enhance the program with connection to the student's experience and really working with counselors to help them go kind of beyond the questionnaire itself. and it's actually provided a unique training. A lot of our counselors that are using it are counseling center interns, and it's really a great way for them to kind of explore the different ways that they can connect with students. And then last is this interactive engagement, making sure that students have a place where they can pose questions and connect with counselors in a safe and secure way. So in terms of how it aligns with this, with our policy priority in higher education, outreach is certainly a key component of this program, and one that we encourage schools to not only conduct outreach just exclusively about this program, but use it as an opportunity to let people know about the services that the counseling center is offering, because it's not necessarily going to be an attractive program for every student. So we want to make sure that if those emails go out to transfer students, that they're also letting transfer students know about some of the other services available to them, whether it's career services or student health services, or maybe a group that they're offering on stress management during transition. And so that's part of this as well, in addition to inviting them to participate in this program. Another way is that a lot of counseling centers partner with different departments within the university. And so they're letting faculty and staff know about this program, so that if they do see a student who may be in distress, or a student sleeping in class, or they've missed a couple classes in a row, they can reach out to this student, let them know about this program and ways to get connected to the counseling center. And so our outreach and that connection is really a big part of this program, and expanding the ways we notify students and faculty and staff about services on campus. And then just that one of the things about this in terms of using this program to kind of expand on services, you learn a lot about these students through their questionnaires and the data that's sort of captured. And so it's really a way for college counseling centers to gather more information about their student population. So a lot of times they think, well, a lot of our students are struggling with drinking and drug use and abuse. And then after a semester of getting these questionnaires, they see, oh, well, a lot of students are struggling with troubles with concentration and academic stress. Let's see what we can do to kind of address those experiences as well. And so they can really build out their access points and some of the different programs that can be available and offered to students on campus. And lastly is just engagement. It's a core component of this program. It's one of the things that is really about not only engaging the students into mental health services through the program, but also engaging those leaders within the school to connect with each other. And so when it's great to hear when you get these stories from our counselors who are using it, and they're like, I have never talked to the head of the Department of Engineering before, but he's such a great guy, and and someone we're going to partner with in the future, because I knew nothing about their students and how they were struggling, or I never knew about the issues that our agricultural studies students were facing, and now we're going to look for different ways to partner with them. And so it's really about engaging not only the students on campus, but engaging the different departments and groups. So that's a wrap on ISP, but there's my contact information. A lot of this program is promoted through our chapters, and we have just expanded to, we're gonna implement it it'll be implemented in a total of 130 schools this fall. So please feel free to contact me if you have any questions. Thank you.
So legislatively around this issue, we are just scratching the surface of what is possible in the higher education area. The legislation is very basic. It just says that colleges and universities have a responsibility to make sure their students know where to go and how to get the care that they need. ISP is so incredibly comprehensive, and any school that is implementing ISP will fit in with that very basic mandate that we would put in legislatively. Now that said, what is currently out there is the information that AFSP has right now, and those are the bills that we've been supporting. I can tell you right now that is certainly not the gold standard. We have a long way to go legislatively to kind of figure out what really is going to work best, but we're getting our feet wet. The legislatures are kind of getting comfortable with the idea of legislating around what's happening in colleges and universities. It's a little bit different from K through 12 because they don't have quite as much oversight as they do with the younger students. So all that is said is that we've got a great resource in Maggie and her department. They have learned so much through the implementation of the ISP, and that's really going to inform our efforts on the policy side, what we're asking for moving forward with higher education. So all that said, I'm opening it up to you all, please. Any questions that you have for the panelists? Yeah, Jen.
This is maybe I should stand up. There's people behind me too, but maybe more of a comment and a question, because first of all, thank you to all of you guys for being here and sharing this information. And then from my experience at the last legislative session, I'm from Montana, and so we were actually able to touch or pass bills related to 2 of the 3 priority areas, and so yay, kudos for that also, because we only meet every other year. So we talked about how slow things go, but yay for that too. But even more specifically for Dave, and a follow-up on that mandatory training for mental health piece. The other flip side of that, because that was one of the initiatives we passed, 6 hours of required training for various health professionals. Mental health was included in that over a 5-year period. And we did have the trade organizations as backing and supporting that, which, yes, I reiterate the importance of that. But the flip side is those locker room conversations and the things that I had heard for the opposition that I would just say be prepared for, because I wasn't necessarily prepared for by my own profession. I am an LCSW. Is that it doesn't recognize those of us that are already receiving some of those trainings. And so, my years of involvement with AFSP, but also just a huge champion for the required training. But I also want to be recognized for that. So if I go to a suicide clinician bereavement training, or if I go to something else that's received national attention, evidence-based practices, there's no way of knowing that I've achieved that except for the passing of some legislation like this. So that can actually be another kind of debunker that I would say when you're having those conversations, and at least it was for me. So I don't know if you want to speak any piece of that.
Yeah, I always want to speak. I appreciate that comment, and it rings true to me. I think that this idea of model legislation is really important, because a lot of people don't know what they don't know about this. This sounds crass, but it's true. A real way to think about this is that if you actually are trained in this, it's going to decrease your liability from malpractice tort litigation. So, Nicole, that's something to think about, that you're much more vulnerable for lawsuits. I hate to go here, but it's there. That mental health professionals that do get trained are doing it mostly out of fear of being successfully sued. So one of the ways I think the crafting of the language, especially for a model bill, is so crucial for just the very reasons that you described. And one of them is you get people in the door out of fear sometimes, but then if the training's good, you're in the life-saving business. So that's really the challenge, is the avoidance, in my bias, the avoidance that mental health professionals have towards this topic, which is ironic because we're basically have the duty from a licensure standpoint to save lives, and to not be trained in it is sort of unbelievable.
Just to follow up on what you're training, recently I'm a mental health professional, the new social media, the texting, can you speak to that in the training for suicide prevention? Yeah,
I mean, my son's high school, there was a suicide about 3 years ago. And I was on sabbatical, and so I was available, to consult and postvention. And I've written about postvention for years, and so this was a chance to actually do it in a very personal way. And we did a textbook job, but the thing we didn't count on was social media. And I called Maddie Gould. I called everybody I knew about this topic, and we were absolutely flat-footed because the young man who I knew that took his life posted everywhere. And the kids were like moths to flame. So there's great virtue in social media. There are also curses with it that are connected. I'm not saying that as a middle ager. I can tell you for a fact that on the intervention side of it, technology and apps are absolutely in the mix. and I would argue is probably going to be central to suicide prevention efforts in the years ahead. But the social media aspect in terms of contagion and modeling effects is pretty stark. So that really caught me by surprise, because we could do textbook postvention, and the end of that school year, I referred maybe 20 kids. There were 4 attempts that I was aware of, and at least a half dozen hospitalizations that I was involved with, because it's a very prominent kid who took his life. So yeah, it's out there. Unfortunately, middle-aged people tend not to sort of be tuned into what that is, but that's where you really need to sort of join with younger people, younger cohorts, to kind of help advise, sort of how can you optimize especially in postvention, but how can you optimize social media versus the problems it can create.
Maggie, is ISP like on a mobile?
Yeah, so
platform
we,
too?
sure, yeah. The question was about ISP as a mobile platform. We have it so it's completely mobile capable, and it defers to whatever phone it's loaded onto.
Sort of a comment and a question. Comment one to Amy. We had a tremendous, I'm from Georgia, we had a tremendous experience with the Trevor Foundation, partnering with them in terms of securing passage of the Jason Flat Act. We put together a coalition that included psychiatrists, psychologists, Parent Teachers Association, teachers unions, and you talk about building the coalition, but one of the things that you didn't touch on, but that we found in going back and talking with the legislators was very important, was that in building that coalition, each of those coalitions had their own Capitol Day, and they said week after week after week, we had different groups coming in here and saying the Jason Flat Act has to pass, the Jason Flat Act has to pass. And in fact, we had several legislators who called up and said, I call Uncle. No more! If you will stop sending me emails to all your organizations, we will vote for your legislation. Which they said it, sort of tongue in cheek, but they also said, crap, we're getting hundreds of emails. And so from that perspective, in terms of not just sort of, hearing sort of the hearings themselves, but in terms of just the broad spectrum of people who were interested and supportive of this, it was very important and very compelling for us. So if you all haven't partnered with Trevor, do. We work with them in a number of different ways in Georgia. We love them. So do what you can. With Maggie, we have a number of, you mentioned Emory, we have a number of universities in Georgia that use ISP. When we're talking with others, do you have data that talks to the issue, which always remains unspoken with colleges who don't want to adopt it, which is they're concerned that if they adopt the ISP, that they're going to get a tidal wave of people, and they don't have the capacity to support that. So do we have any data that says when we implement it, what has been the response in terms of the student community? I mean, we will argue and say, that's why we need to do this, is to sort of give you the scope of it. They're saying, I've got budget for X, and I'm going to need 3 times that budget.
Yeah, no, that's a great question, and certainly a concern for, I would say, every college and university counseling center across the country right now, which I think speaks to some of the work we can do with our policies. We have several publications on the program. They should be on our website, afsp.org/ISP, and they do speak to that it doesn't bring these high droves and high numbers of students in. It's really about a 10% response rate for those invited students, which is really who are all about 90% of that 10% are in high distress, and about 95% of them are not utilizing any type of treatment. And so we're really getting this small, that 15%, that 10 to 15% of students who are in distress and are not using services, but it's not high numbers of new students or new patients into the counseling center. And our publications speak to that. Thank you.
Well, unfortunately, I have to call time, and I'm sorry to do that, but please seek them out. David does have to run. Amy and Maggie are sticking around.
Yeah.
And if you guys have any questions for David that you didn't get answered today, please reach out to me, and I can get them over to him. Thank you guys. Thank you.